back in the day, I'm sure, back in my day, not your day, you know, you played a sport for a season and then you switched to a different sport, and now there's so many overuse injuries because they play year round. They never get a break, and their parents push them like crazy, and it drives me nuts. And but anyway, it's one of those things. So when you have kids, make sure that they play different sports. No. but it's really important because you need to rest those muscles and let them heal. But you would be amazed that, you know, you get these 13-year-old baseball players and that they pitch every day, every year, and they come in and their shoulders are like this. I'm like, okay. And all it is therapy and taking a break and letting those muscles recover that gets it better. But anyway, that's my soapbox. I'm sorry. So anyway, so you're checking the height of the shoulders, okay? And you're looking to see if there's any obvious muscle atrophy. So the rotator cuff, you know, it's 4 different muscles. One sits up here on top of that spinous process of the shoulder blade, and then 2 are down here. I'm sorry, and then underneath the shoulder blade is that subscap, which is so it's that whole shoulder blade is kind of pancaked by 2 different, you know, big muscle groups. So if all of a sudden you see just a huge like atrophy dip here, and you don't see that here, that's important. Especially if you've got like an older gentleman that's noting that he can't lift his arm up. You know, he might have had a rotator cuff tear for years, but now it's bothering him. And then you're also looking at, you know, height and everything like that back here, because sometimes you can notice it this way rather than looking at it from the front. So, and then palpation. So there's 4 really, you know, parts that are pretty important to palpate in the shoulder. AC joint, so where the bump is on the shoulder, go just lateral to it, okay? And push down on it. So, is it just cold? Yeah, sorry. Women hate it when I do the breast like it warms up by the second one, don't. All right. So you just want to kind of, and if it doesn't hurt back here, but everything in your mind based on history, and they're like, oh, when I lean back or if I grab something out of the back seat, it hurts every single time. You know, if you're pushing on the front and it doesn't hurt, push on the back. You know, kind of go around that distal clavicle and see if you can get it to hurt, because it might be that it's just touching and irritated on that back end, and you can usually make them jump. So AC joint, really important, especially in women weightlifters. And then coracoid process, so that finger bone that's underneath that clavicle, poke at it. If you poke at it hard enough on anyone, it's going to hurt. Overweight, obese people, it's harder to feel. But that coracoid process, see if that hurts. In throwers, it almost always hurts. It's part of this whole scapular dyskinesis, or, you know, problem with it, thrower shoulder, it is. And then that rotator cuff insertion, which is right about here. It's just so you get to the acromion is the flat bone here. You go just lateral to that. That's where all of the not all of the rotator cuff muscles, but a big chunk of them insert here and here. So push on it, see if it hurts. But like I said, it's not a great test because it doesn't always, you know, replicate symptoms even in light of a rotator cuff tear. Biceps tendon. So actually, when you're looking for the biceps tendon, you can actually grab it, and you kind of have to dig in there. But you just think of like right in the front part of that armpit. If we ever operated, you know, we would cut right here, and it goes right down to that biceps. But it traverses along here, and you can push right here. Do you feel that? Yeah. Yeah. Just a little bit. Yeah. So like a free massage. Yeah. I'm not even mad at them. And so you're trying to feel that bicep tendon. You can feel it rolling under your finger. Okay. So those are kind of the 4 big parts to feel. You know, some people note pain at the SC joint. If you do, there's not a lot that you do about it. I tell people that, you know, there's sometimes injections for those areas, but they're under, you can imagine the arteries that lie under there. We don't want to mess with those. And so I send them to a radiologist and say, you inject it. So, but very rarely do you actually get pain at that middle aspect of the clavicle, which is good because it's not a fun place to have problems. But in the shoulder, those are the big spots. And I'll let you talk about neck and upper travel.
Yeah, just thing I want to add to that is we see a lot of shoulder dislocations, and that's a really good inspection. They don't want to move, like they're going to be like this, because it's the most comfortable position for them. So what I always do is when I take their gown off, the first thing I do is I look, because you're going to see that the normal shoulder is not nice and high. The dislocated shoulder is, there's a divot, and then you can see that the humeral head is right below it. They don't want you to touch it, obviously, but it's obvious when some people come in and they have shoulder pain and they say, I think we dislocated it. You look at it and you're like, So the inspection for that, and I just know sometimes it is really obvious for some people.
Yeah, and the same thing goes for inspection on like shoulder separations or AC joint. You know, it's not always obvious in a very mild one, and they'll guard their shoulder like crazy too. But sometimes if it's a really good one, I mean, you'll see that it looks like this bone is coming out of the shoulder, but it's not. It's just that ball has dropped down.
And you almost assume it's a fracture.
Yep. Yep.
Yeah.
So they need to, but so that's gonna, inspection, palpation, and then range of motion. So in shoulder, like I said, it's the most mobile joint in the body. So you're going to have the patient kind of face you because you want them to replicate you. So you get your exercise too. So you have them come up and replicate. And if they're like this, you just say keep going with your good arm as far as you can. But with the shoulder, the bad shoulder, just say get as far as you possibly can. Sometimes if they're like, just I don't think that they're in that much pain. I tell them try to get through it and see if it gets better when you get to the top. Because if you have bursal impingement or irritation of that bursal sac that sits on top of the rotator cuff, there is pain from about 30 degrees to about 160, and then they get back to this 160 to 180, and they're fine up here. But that whole part, they're like, but then they get up here and they're like, okay, this is better. So that's really important to know, because if you have a rotator cuff tear or another process like frozen shoulder going on, which granted they're generally not going to get up that high, that's not going to make them feel better. So forward flexion and then abduction, coming out away from the body, so like a jumping jack, so have them go that way. Yep. And external rotation, so you're going to have them keep their elbows by the side of their body, and people love to go like this, keep your elbows here, come out this way. Where this is really important, it's looking at, for like frozen shoulder. So you want to see if all of a sudden they're like this, that's a red flag. So external rotation is really important. And that's stressing the AC joints too when you do that. So, and then I have them actually do this test coming up this way. If you have a really, really big rotator cuff tear, you can't lift your arms like this. So that's just external rotation with 90 degrees of abduction. There's not really a scientific name for it, unfortunately. I'm sure someone will create one at some point. But, and then internal rotation behind your back, because you can have them do internal rotation here. It's hard to measure. Some people do a lot of muscular guarding, and so it's not a good test. So, but have them do it one at a time. So internal rotation behind your back, so as high as you can go. And then mark it with your finger, okay? And do the other one. And that's good. So throwers, people with like thrower shoulder and obvious like scapular issues, they're going to be like here, and then you're going to have this one up to here. And so there's going to be a huge discrepancy. Or frozen shoulder, same thing. Most of the time they won't even be able to get past like their hip, which is why one of the important parts in the history of frozen shoulder is that like an older gentleman, they had to switch their wallet from one side to the other because they can't get back there anymore.
Or the woman has to
switch, spin the bra because they can't do it anymore. So, so those are important for range of motion. Any more that you do, and then passive range of motion, doing the same thing, but I'm doing it for you. So I'm taking the shoulder and I'm just moving it for you. Okay. So you're going forward flexion, you're going abduction, and then while they're up here, I kind of do this motion here, and you can't really do this for somebody. That's when I do this, okay, and I compare it to the other side. But you have to make sure that you're relaxing that shoulder down, because otherwise I can get a heck of a lot further if you start going like that, right? So you have to.
Laura said some people are so apprehensive with this.
Yeah.
They don't want you to touch their shoulder. I don't know
adaptation here. And this one's really important. Like I said, frozen shoulder and just overall, if you've got somebody that's hypermobile, they'll come like, it's almost scary. You're like, I'm gonna keep going, you know? Or if they've got a really big subscap tear, you can dislocate them because the subscap keeps it in the shoulder, you know? So I've gone like this, I'm like, oh, that's coming out, let's not do that. So, yeah, but yeah, and you want to compare it to the other side and say, sometimes I end up going like this on a patient where they're like early frozen shoulder, I'm like this, and I think that they think I'm crazy because I keep doing it just to see if it truly is or if it's just me on the exam. So, and then strength testing. So out here you're testing the supraspinatus tendon. So push up. Okay. But one thing in throwers, when you test their strength, they're really strong the first time. Keep doing it. Make them do it at least 3 or 4 times. All of a sudden, do it again and again. And then all of a sudden, they're like, you know, and you just, and these are like, you know, strong, mighty little 13-year-olds. And they're like, you know, and I'm like, don't use your back, you know. But it's amazing because that first time you would be fooled saying that the rotator cuff is really strong. And so even in my notes, I'll say, you know, fade significantly on 3rd attempt, you know, and usually that's just because they've been using substitute muscles rather than actually using that rotator cuff. So that rotator cuff is super weak. So forward flexion and then something like this, don't only push out. Very rarely does this ever hurt. Frozen shoulder hurts. So, and then arms up like this. Don't let me push down. If you have a big rotator cuff tear, you're just not going to be able to do it. Yep. So those are kind of the big ones because some people, you know, do like try to do forward flexion resistance, but if you do it at 45 degrees, you're hitting, you know, both the supraspinatus and infraspinatus tendons. So you don't really need to do forward flexion. This is an awkward motion to try to resist me. So if you have them at like 45 degrees, it's just a better exam. Do you do anything different?
No, not. I would say that I do, I don't remember the names of the ones that you were talking about here. I do those a lot if I suspect like rotator cuff.
Yep.
I see a lot of frozen shoulders specifically. I mean, sometimes I can't tell the difference, but more like rotator cuff injury if it's been like an actual injury. But yeah, that's what I do.
Yeah. Because I mean, and remember, you don't always, you know, I'm sure that you get to see the rotator cuff tears that are traumatic. You know, I mean, in primary care and in sports medicine, we get, you know, you can have attritional tears. So you can have tears that they're like, I don't know what I did. It hurts and I can't move my arm. And so they might have a rotator cuff tear because they're just predispositioned to it. They had a physical job their whole life or whatever, you know. But that's why history is so important. Take a really good history so that you can kind of hone in your physical exam because you don't have to do the entire physical exam every single time. If you say, okay, based off this story, this is, you know, a rotator cuff tear, this is bursitis, you know, that's, it's going to help you. But if you get to your physical exam, you're like, okay, this isn't fitting, then do the whole thing. Because if you go backwards, the patient doesn't know. You know, they just need to figure out what's going on. And if you can't figure it out, ask somebody else because, you know, shoulder's hard. It really is. It takes time. And like I said, when I first started in shoulder surgery, I hated the shoulder. I was like, what am I doing? But I had a good teacher, and so, and I want to show you one other thing. So special tests, they say an empty can test, okay? I don't ever use this test. I just use strength for rotator cuff, but you should know it because it will be on your boards. I almost guarantee it. But the empty can test. So if I push this way, and that hurts.
Weird.
Yeah, it's a weird motion. But do you just drop? That's the empty can test, and it's testing for a rotator cuff tear. So rotator cuff tear, empty can. And then for bursitis, that test is it's called the Hawkins-Kennedy. I mean, do you have it called other things? I mean, there's some people call it the Hawkins, some people call it the Kennedy. I don't know.
Might have been a Kennedy.
Yeah, but it's.
I don't even remember the test.
But either way, this one's hard because people think you're going to do something fast and make their shoulder hurt when it already hurts. And so you have to. This is one where you really, really have to get them honed in on relaxing. And so I'm like, shrug it out, and I'm like doing it with them, you know, because otherwise they're always like this. And I'm like, drop it, you know, because you need to have them just be a noodle. So just drop that shoulder down. Just seriously shake it. See, and it drops. See, it actually did drop down a little further. So I have her elbow here. If her elbow, you know, if they're complaining of elbow pain, I'm like, it hurts. And ask them where, because if they're like an elbow, I don't care. I'm looking at the shoulder. It's not that I don't, but it's I'm trying to hone in on the shoulder. So you have her totally relaxed, and you're pushing like this, okay? And what they'll say is, you know, because bursal pain, impingement pain, it can be here, it can be here, it can be here, it can move all over because the bursa is a huge sac that sits right over the shoulder. So it's not a specific, like if it's anterior shoulder pain, it's going to be this. In impingement, it can be anywhere. But if you do this, you're really pushing on that bursa, and if they're like, okay, that's my pain, then, and that's one important thing is if it's recreating pain, is it the pain that you're experiencing or is it a new pain? Because if it's not what you're experiencing or what we're complaining about, we still have to look. But that's a really, really good test. If you've got AC joint issues, one way to differentiate between bursal and AC joint, because sometimes they can go hand in hand, is it's called a crossbody Hawkins-Kennedy. I think that one was made up. I don't think it's the official name. But you can imagine if you cross your body, you're going to put stress on where the acromion and the distal clavicle meet, and you do that same motion, and it's going to be like sending somebody through the roof. So,
if it was which one?
the AC joint.
Okay.
Yep. So, out this way, it's just impingement and bursal irritation. This way, AC joint. So, and you can just I mean, visualize it. You're really stressing that AC joint if you push it this way. And most of the time with AC joint issues, when you ask them to do that kind of bra motion, they're not going to want to do it, or they're like, oh, that hurts. So those are kind of the big ones. And then lastly, as far as this kind of goes back to inspection. So when you're having somebody that's got really, you know, cockeyed shoulders, or not sitting straight, yeah, just like that, then you want to have them turn around. And you want to look at the, yes, so you want to look at the back of their shoulder blades, okay? So I'm going to have you do that forward flexion, but I'm going to have you do it repeatedly, but I'm going to have you come down slow. And what you want to do is you want to find where that inferior, that inferior part of, do it again, that shoulder blade comes out, and you want to make sure that they pop out at the same time. And in somebody with really, really bad thrower shoulder, it's going to go boom, boom. You know, it's going to be super obvious where they pop out on one side, and then it's almost like a 1 to 2 second delay where they come out at different times. Or if you put your hand on this inferior aspect, one's here and one's all the way down here. And it's not that it's actually lower, it's rotated. So that's a really important part of kind of that sports medicine, especially in younger, or in somebody that's a repetitive thrower. Sometimes in golfers, actually. Doesn't happen very often, but yeah, so that's kind of, there we go.
Is throwers arm okay?
Thrower shoulder?
Yeah.
Yes, but there's different names for it.
Okay.
In sports medicine, a lot of people like to call it little leaguer shoulder, thrower shoulder. GERD, which is glenohumeral internal rotation deficiency, which is basically meaning like if you were to take that internal rotation and do this, if I did it on one side, you would be, so let's say you're like, because your 0 is here, so you're 40 degrees here, and all of a sudden you'd be like, well, you actually do have a good hyperextension, so you are, you know, plus, because here's your 0, so you're plus 10, so you've got, most people stop at 0, but it doesn't mean anything's wrong with you, it just means that, we gotta talk. But she's got the same here, you know, her external rotation is the same, and her internal rotation is the same, and so you just want to make sure it's the same on both sides. But in throwers, sometimes what they do is what they lack an internal rotation, all of a sudden they gain on their throwing side, because you've seen pitchers, they hyperextend and they come back and they've developed that and tighten their capsule enough so that it's still the same arc, but it's in a different spot. So that's called glenohumeral internal rotation deficiency, but they make up for it in external rotation, but their internal is gone, but it hurts like steak.
So what I first do is, the inspection's pretty quick. You can look in the front too. You start palpating the midline spine. And you feel, you try to get on every vertebrae if you can. You're probably not gonna get C1, C2 very easily. And you push down and you wanna ask them, does it hurt midline? It's important for know if there's been any trauma, if it hurts midline. So you go down to the center and you find the vertebrae. Usually C7 is the easiest to find, is the one that protrudes if you notice on your neck. That's about C7. And then sometimes I go down to T1 just to see where I'm at. If there's no tenderness there, then I go paraspinal. So I normally start on the left, it depends what side I'm on, and you want to push off just to the side. And is it sore here? And you'll push through. You go down here, you ask them, does that hurt? And then I'll do the right side. And if I say, does one side hurt more than the other side? And if they say no, sometimes they'll say yes, because they're there, I see for pain. So then I go down the other side. Then what I normally do is I go down into trapezius muscles too. It's kind of like upper back into the neck. But you'd be amazed when they say neck pain, they grab right here. They'll grab here and like into the back, and maybe their neck itself doesn't hurt, but the upper back does. So then I start palpating in here, and sometimes I squeeze right there, and then they like go down like this. I know that's kind of the location I'll do pain. So that's more like palpation in the neck specifically. Sometimes they'll have some pain and they'll have some weird lymph nodes up here. You also have to look at that. So then I have her do the flexions forward, and if that hurts, it's good to know. And then extension off the back. Good. And then you want to laterally rotate left and right. If there's any pain there, especially if there's a trauma, if they come in with the C-collar and I try to evaluate them, if they have any pain when they do anything, and I put the C-collar back on, or I don't need to take it off. They can't move it side to side if they have the collar in, but you can certainly palpate the spine by holding them in C-spine percussions. And some people like to do this lateral one. I don't know if it really does much for them. They just, I think, feels good. I don't know. They just like to do it. So that's part of like the whole range of motion, the strength. I know we were talking about. If you want to push against the neck, so push against feet. And then sometimes that will hurt them. If you notice, does it hurt more on this side? Does it hurt on one side? That's worse. No, does it hurt more in front? Okay. Or the other side. Just try to get something. And then sometimes they'll just quit on you. If it hurts, they'll just stop. Like that's natural. So that's good to know there. So the neck is pretty quick. There's not a whole lot of fun tests to do or names. We just do it. Now as far as the back, same thing. You just go down the spine. So you want to look. First of all, you want to see what they're doing. Some people don't like to be undressed for you. You have to undress them. And you have to look at the entire spine. If they're not willing to stand, what I like to do is have them rotate on their side. And then you can just take a look at the spine. Sometimes it's not the straightest, especially if they're on one of our beds. But look again for any ecchymosis, any swelling. Some people don't realize that they have a weird rash on their back, or if there's been a weird skin abscess or something like that. You want to look to see what's going on. And I go all the way down to the upper buttocks. And then so that's basically my inspection there for that. And then palpation is the same thing. Try to hit every spinous process if you can. And the obese patients are really hard to find the spinous processes, but you do the best you can. You go down midline all the way down. You do the same for the paraspinal, left and right, all the way down. And if they have specific pain, even if it's more of a traumatic event and they have pain right on the spinous process, then we usually get an X-ray. If there's been any direct trauma, if there's been a fall, if there's been an assault, or there's been something, we get an X-ray to look for a spinous fracture of some sort. You'll see a lot of, do you mind if I lift your shirt up just a tad? You'll see a lot of pain that kind of sits around in the lower back. You want to turn a little bit.
This is where you get
Yeah, so a lot of the pain is probably going to be from here to here and here to here. That's what we see a lot of. And whether or not it was a direct trauma, I just had a guy the other day who was changing his tire, and he was doing some of the lug nuts, and then all of a sudden felt this pop in his back. But it's really important for you to get a good midline and paraspinal tenderness exam, because if it's off to one side, it's likely muscle. And there's no way you're going to be able to determine the difference whether or not it's a disc or not. However, it's by history, maybe what they're talking about. It's all about, like, is there leg weakness, is there anything else that goes on? upper body, they turn weird to go for something like this, and they strain that part of their back, and it's really sore, and it's uncomfortable. But if it sits right here and here, these are your rhomboids, and of course these are your trapezius muscles. You know, I actually document that. I'll say tender to left rhomboid muscle, and I'll explain it to them. But down here, same with the palpation you're doing up here. You do the best you can. Sometimes they're not really loving when you're touching them. But if you can get them to stand, you can actually do some range of motion with them. I do recommend it. Usually they're in the bed and they're not really wanting to roll over. The best position is fetal position or laying flat on their back. I don't recommend, for some reason, some patients love to be on, like prone on their stomach when you walk in. That's probably the worst position they should be, because in order for them to get up, they're going to have to flex all those back muscles, and they don't realize that. So I tell patients, never ever sleep on your stomach, never ever do any of that. If you have any back pain, it's just going to make it worse. So, as Laura was saying earlier, turn this way. So, if you want to test flexion extension, it's pretty easy to do it. So bend forward. That's your flexion. And bend backwards. It's your extension. It's the part where you want to hold the hips for them to laterally rotate. Because as she was saying before, they'll do this. And that's not what you're testing. So you want to hold, and then you twist the upper body. Yep, exactly. And if it hurts, they might twist to the right. Sometimes you have some pain off to the left. And they'll tell you. Or if you can palpate certain areas that become a little more stiff or a little more firm, maybe it's a little more straight there. Do you know for the back, do they like us to do reflexes and all that stuff?
I guess I would assume.
It would
but
be
I
a
don't know.
pullback exam
Yeah.
for me.
Yeah. I would
So that's normal, like, back pain, there's a bunch of things you have to think about other than just trauma. So we always want to make sure the spinal cord is not affected. So what I like to do for every back pain, if I can, is to get the strength of the lower extremities, the reflexes, you know, she was talking about the straight leg test, and then the great toe is also really important. So,
and a rectal.
I know.
Always offer it.
And
then you can decline.
Right. Right. If there is some issues with the rectal, or yes, I have to do it. I do a lot of rectal exams in my career. It is what it is.
Not always a problem.
Not always. No, and the patients aren't really, they don't really love it either. So I can show you how to do reflexes. Do you want to grab a chair? Can I sit a chair?
We
So,
got rectal.
you're not going to, what do we have here?
How does
Keep
it
it
look?
in. I usually use my stethoscope. Actually, I can show you a cheat.
I'm sure there's one somewhere.
Maybe my drawers.
Yeah.
Someone had kind of a big pen.
Anybody have a big pen?
Use like your phone.
I think it's probably a very expensive reflex.
Probably is. Raise your try.
Just use your phone.
Okay. We need like a graphic. Higher.
What about a table?
Yeah, sit on the table.
Yeah, so that's good.
Yeah, you can set it up in the middle here, maybe.
Just have someone sit on the other side. Do you want to sit up here? Sit on here. Someone else sit on the other side here.
You're doing well.
So I don't usually get everybody in a sitting position because they don't. So to see if this works. What I use is, I don't keep a reflex camera with me because the ER things get lost all the time. I use my stethoscope. What I do is I find the area of the bell right at the bottom, like the circle part, and I just hit it right like this. And 90% of the time I get it. It's usually the obese patients that it's really hard to get on. So you want to find the distal portion of the patella here, and you want to find the little divot that's right there. Okay, and you can find it, and you have to make sure they relax. If they're flexed, like flex your knee up, or yep. And this is really hard, and it's going to be really hard to get reflexes. So you find the other side. All right, we'll see if this works. I'll just go straight up. So I do that, and if it doesn't hurt you or you have appropriate anatomy, it's going to work just fine. And you go to right below it, and you hit it again.
Do they usually laugh?
I always laugh. I don't know why.
Sometimes they're amazed at how good of a reflex they have, and they just don't know it. That's how you
Yeah, you're using a marker, which is even more expensive.
Right. So I guess I've done a lot of reflexes, huh? But sometimes they have to sit them up because they can't relax. You know, what I try to do is I try to hold their leg, and what I can show you if you want to lay down, you can be okay.
Yeah.
Lay this
Oh, and if they've had knee surgery too, sometimes they damage the reflex of the
Right.
patellar tendon.
Right, so if they bend their knee up and then they say, oh, and I have to see this big central scar off to the side, you know,
The reflexes are
surgery. Okay, I don't mean to get into anybody's way here, but I'm right-handed, so I gotta do it this way. So relax your leg, can you, like, dead leg. And I hold it here, and she's nice and relaxed here, so what I do is you get a little one that's not as good as if they're sitting, but they sometimes won't sit for you. So you get that one, and then let's do the other one. Okay, now relax again. And again, stethoscope a little bit better than this. I'm not blocking anybody, so we'll try it again. So you get a little bit right there, and then you don't have to move the patient. Actually, I'm sorry, maybe I got it. My hand is too, put that over there. Okay, and then for further back exam, you want to test strength. Then move up to the side, right? Okay, straighten your legs. So it's important that what you want to do is you always want them to push down, pull up. This is testing the spinal cord. So I'm going to get underneath here. I want you to push down. And I push against them. Yep, I resist. And then you pull up. Okay? And then you want to push them inward, and push out. Good. And then, I won't make her take her shoes off. But you want to get over the great toes. And you lift your great toes up. Good. And then you push it down. That's really important on that spinal cord. And then, with your knee straight, lift this straight up. Here's your straight leg. Good. And I would say majority of people with back pain can actually do it pretty well. They don't want to, but they will try. Do the other one. Good. And sometimes, I'm just going to use your leg as an example here, they'll only go to about right here. So I document maybe like 15-degree flexion, and I'll say same thing to the other one, and they might be able to go like 30 degrees. So I document that and see where it starts to hurt them. Okay. Thank you.
Mm-hmm.
Trying to think of anything else.
Do you do Achilles reflexes at all?
Not as often,
Yeah.
but yeah, sometimes they're really hard.
Yeah.
They're really hard to get, and it's just about how the patient can like relax. And then if I'm really concerned about like cauda equina for the back, then I'll try to get as many reflexes as I can, but it's more patellar.
Yeah.
But I don't know if I would even give it with that pen. So
Yeah.
So if you had that, we just talked about, what was that, cauda equina?
cauda equina,
Syndrome?
yeah, it's really
You
rare.
wouldn't get a patellar?
It may be decreased.
Okay.
Yeah, and it's really rare. I think, of the physicians I've worked with that have practiced for 20 years, they may have seen 1 or 2 cases, 3 cases, but it's what we have to check for every time in the ER. And this is, not everyone needs an MRI when they come into the ER to look for cauda equina. So we do all these really specific exams, and you document it, and you just say, okay, strength was normal, sensation is normal, or like more specific than that, but like the reflexes. And then another thing for back to do like strengthen the spinal cord is you can have them walk on their tippy toes, walk on their heels, things like that. So it's going to look more extended back exam, but it's also you want to think about spinal cord and stuff like that.
What was a straight leg test you said would be indicating?
Herniated disc generally, but what it would do is it would generally recreate their pain, but their pain, they would usually have numbness and radiation that goes beyond the knee, and that's kind of the key point. Is if it stays proximal to the knee, that's usually okay. It's when it goes beyond the knee, that's where you kind of need to delve a little further.
So is the positive test, like the numbness and tingling, or the inability to perform a straight leg raise?
Well, a true positive test is it's not necessarily numbness and tingling. It could be pain, but beyond the level of the knee.
Okay.
So that's considered a positive test. But
And they may
if
not lift it for you.
you could say, if you were writing up a note, let's say she could only do it because it was limited by pain, but it didn't go beyond the knee, then I would note that specifically. So, and even if you have a herniated disc, most patients are treated conservatively. If you hydrate really, really well, you can actually pop, you can basically hydrate a disc back to pop back in. It doesn't happen quickly. So it's not like giving them an IV, it's just going to pop back in. But physical therapy, anti-inflammatories, pain medication, people think that herniated disc means surgery. It doesn't. And the vast majority,
Surgery did all that.
Yep. And it goes away. Yeah.
You just have to reassure the patient that most conservative therapy does actually work. I don't know, you said you were just shoulder?
Well, I'm in primary care now, so I do everything now.
For my career, people obviously, when they hurt themselves, they want to be seen right away, and they want answers right away, and they want imaging, and they want all of this right away.
And they want immediate relief.
They do. They want immediate relief, and it's not going to happen. I mean, rarely do we order an emergent MRI of the back. If there's been trauma, maybe a CT. Even X-rays are not as much as they used to. So it's more the physical exam. You know, if there is a herniated disc,
You still
you-
treat them conservative.
you do, and I hate to say you don't care as much as long as their strength is normal, their sensation, their reflexes, and all of that is normal. From the ER standpoint, you don't suspect anything bad. And the discs can get better, or if they are willing to wait to see their primary clinic, then they can go in and get physical therapy, which probably works the best, right?
Yep.
And see, we never see patients come back, so I
Well,
don't know how well they do, but it sounds.
And people think that, you know, like anti-inflammatories, they don't work. I need Percocet.
Right.
Honestly, Percocet doesn't do anything for back pain except mask it. But if you do like prescription strength, you know, 800 milligrams of ibuprofen every 8 hours, they get better because it's helping that inflammatory cycle. I tell people, think of it like an antibiotic. Take it every single day, pending no like super high blood pressure, kidney disease. Remember those caveats. Diabetes. You know, take it 3 times a day, or I put them on steroids, and I don't put them on a medical dose pack because I don't like them. I put them on a really high dose taper, and all of a sudden they're like, "This is magical," and I'm like, "You do, you know." I'm like, because we need to fix the problem, not just mask the pain. And muscle relaxants, people like them because they help them sleep. It doesn't really do a whole heck of a lot, but I give them out like candy because it's really not going to hurt.
Yeah. Then they try to limit any narcotics from us that are non-traumatic back pain. So even if it was my guy who was changing a tire, he did not get narcotics for me because my exam was consistent with muscle. He did have some back issues in the past, but I said ibuprofen, and we use Flexeril sometimes. Sometimes we give Valium, which can be used as a muscle relaxant for like kind of some immediate relief.
And it has anti-anxiety properties too, which always helps.
Yes, and then they're like, "Oh, this is really nice." I'm like, "You can't drive." So, yeah, but we try to limit the narcotics. Now, if it was a traumatic event, I get it. They're going to be sore. It's different. We still try to limit it, but it happens.
So you guys want to just break off like half and half and maybe do exams on each other and just see where you have questions and ask us?
Do either of you mind if because I recorded this, if we put this up on our class page so we can watch it?
Oh, that's fine.
Is that fine? You're fine with that?
Thank you.